Hi, I'm Pain Dr. Nicholas Scott. Today we're going to review the components of a comprehensive physical exam. One of the most important aspects to our jobs as physicians is to provide a thorough, comprehensive physical examination to each patient. This exam ensures that we are going to cover every potential painful area the patient is experiencing. At the start of the exam, I ask the patient to stand. This allows for assessment of station, also known as stance. Station is assessed by having the patient stand in their typical stance and can include visualization of the spine for conditions including scoliosis, thoracic kyphosis, and lumbar lordosis. Next, I ask the patient to walk in the exam room. There are a variety of gaits to look for while the patient walks. These include antalgic or a shortened stride on one side, spastic, which results in a restricted range of motion across a joint, steppage or weakness of the ankle dorsiflexors, as well as circumductive. I then ask the patient to walk on their toes for a few steps, then heels for a few steps as well. This tests balance and assesses the strength of the muscles controlled by the first sacral nerve root. More specifically, it tests the gastrocnemius for toe walking and the muscles controlled by the fourth lumbar nerve root for heel walking, including the tibialis anterior. After the walking exam, I have the patient attempt to touch their toes and then lean back. This evaluates lumbar flexion as well as extension. I then assess the lumbar spine by requesting the patient stand with their back to me and displace any clothing overlying the lumbar spine. I look for any scars, rashes, lesions, or ulcers, followed by palpation to assess the lumbar paraspinal musculature, the lumbar facets, the sacroiliac joints, the piriformis musculature, and the greater trochanteric bursa. A useful anatomic landmark is the top of the iliac crests, which typically correspond with the L4 vertebral body level. If the patient has reported lumbar region pain, I will request that they use one finger to point to the most painful region. Provocative testing is done in this position, including lumbar facet loading to assess this region by requesting the patient lean or extend back and rotate to one side. I place my hand on the rotated side's shoulder and apply axial or downward pressure. If this reproduces the patient's typical pain, then facetogenic etiology should be considered. The cervical spine is then assessed. I have the patient flex and extend, laterally rotate, and laterally flex the cervical spine. Next, I look for any scars, rashes, lesions, or ulcers which may be present, and then palpate the posterior cervical region, including paraspinal cervical muscles, trapezii, and cervical facets. Palpating the submandibular lymph nodes assesses the lymphatic system. Additionally, the cardiovascular system is evaluated by palpating the carotid arteries. Provocative maneuvers including facet loading for axial pain and Sperling's test for radicular symptoms are also performed during this time. The seated examination begins with a top-down progression starting with the cranial nerves. I examine eye movement that includes the third, fourth, and sixth cranial nerves, and facial sensation containing the fifth cranial nerve. We then look at eyelid closure, eyebrow raising, puffing out of the cheeks, and smiling, which examines the seventh cranial nerve. Hearing is examined by finger rubbing, which assesses the eighth cranial nerve, shoulder shrug and resisted lateral rotation of the neck, which examines the 11th cranial nerve, and finally tongue protrusion, which includes the 12th cranial nerve. Next, I examine the upper extremities. Each extremity is evaluated for four key components: strength, sensation, range of motion, and reflexes. Strength is evaluated through manual muscle testing of the upper extremities. I evaluate the shoulder abductors, typically controlled by the fifth cervical nerve root, elbow flexors, C5 as well, wrist extensors, which are C6, elbow extensors at C7, and finger flexors, which are C8, best assessed at the distal phalanx of the long finger, and finally finger abductors, which are T1. During the strength inspection, I note any misalignment, asymmetry, tenderness, masses, any effusions, atrophy, or swelling. Assessment of stability, looking for any laxity or dislocation, and tone, looking for a spastic or flaccid extremity, is completed during strength testing as well. After thorough exam of the upper extremities, strength testing of the lower extremities is performed. I examine hip flexors, generally controlled by the second lumbar nerve root, knee extensors controlled by the third, ankle dorsiflexors by L4, great or long toe extensors, which are controlled by L5, as well as ankle plantar flexors, which are controlled by S1. Hip abduction strength, range of motion, and assessing a seated straight leg raise is also completed during this time. Sensation is also assessed using a light touch and either a pinprick or an alcohol swab to assess the spinal thalamic tract, because both temperature and pain sensations travel in this tract. Generally in the upper extremities, the C5 through T1 dermatomes are assessed, with the patient's hands pronated or facing downward, with C6 at the thumb, C7 at the long finger, and C8 at the small finger. The L3S1 dermatomes are then evaluated in the lower extremities, with L3 at the medial aspect of the knee, L4 at the medial malleolus, L5 at the dorsum of the foot near the great toe, and S1 at the lateral aspect of the heel. Next, we evaluate the reflexes by assessing the biceps, which is C5, brachioradialis, which is C6, and triceps, which is C7. Extending and stabilizing the long finger and flicking downward on the patient's distal phalanx with your thumb can provide a good test or assessment of the Hoffman's reflex or sign. A positive sign occurs when the distal phalanx of the patient's thumb flexes. This may indicate pathology in the cortical spinal tract. For the lower extremities, the L4 and S1 reflexes are assessed at the patella and Achilles respectively. Stabilizing the ankle joint and applying rapid upward force against the base of the toes while looking for a rhythmic rapid upward movement of the foot leads to assessment of potential clonus. A Babinski reflex or sign could occur as indicated by great toe extension when force is applied against the lateral plantar aspect of the foot. A positive finding might indicate spinal cord dysfunction. Finally, an evaluation is completed with a patient in the supine position. In this position, we can evaluate for potential radiculitis or nerve root irritation by a supine straight leg raise. Hip range of motion can be assessed as well, and downward pressure through the hip looking for a potential sacral insufficiency fracture can also be performed. We can then perform a Faber maneuver, also known as flexion, abduction, external rotation, and extension to evaluate the SI or sacroiliac joints. Keep in mind, evaluating every painful area through the assessment of all four extremities is important during the exam. Perhaps the most important part is to assess the lumbar and cervical areas on the majority of patients. The goal of the comprehensive physical examination is to detect a large percentage of deficits that might pose a significant detriment to patients, including such neurologic conditions as spinal cord dysfunction. Thanks for watching this demonstration of how to conduct a comprehensive and thorough physical examination.